Thank you very much for this invitation. Mr. Chairman, ladies and gentlemen, Borg Nordiskard, always a hard act to follow. So anyway, look, I'm just going to supplement this with some practical advice about the management of FH. The 7 sins of FH are the gaps in FH, the under everything. You can read that for yourself, under-recognized, under-treated, under-efficient care, so that in response to this gap, there's been a number of position statements, starting with the NICE guidelines, the NLA guidelines, the Australian guidelines that were published in parallel with that, the European guidelines that you've heard, and also this international consensus guideline. That is not often as quoted as the others, but in fact it was an integrated guidance that included everything to do with FH, and it wasn't split up into 3 different articles. But many of the people on this were on the previous ones. So, so in the basic notion of those guidelines is to improve care, and this is, as it were, a heuristic, if you wish, or a rubric, a rule of thumb, that the anatomy of care for FH, or indeed for any condition, could follow this pattern. The detection of index cases, diagnosis, assessment, genetic test, management, organisation. I mean, Borg has been through many of those elements, and I'm going to pick a few and take you round the clock in the next 35 minutes or so. A little note about detecting index cases. The screening options are opportunistic, targeted, and universal testing. I want to tell you a little bit about opportunistic testing, because these were a series of papers that a PhD student, Damon Bell, who's just finished his PhD, is the role that the laboratory may actually fulfill in alerting GPs to the possibility that their patients may have FH. And he looked at various approaches to this, including ringing them up, putting an interpretive comment, and this was generally quite effective at alerting the primary care physician that their patient may have FH, with an increased number of referrals to the specialist clinic. The other approach is in primary care using an electronic tool called TARBX that employs structured query language SQL technology. And this is applied to a series of, if your GPs have medical director, so this software is applied to the databases and can interrogate, GPs' history and other details. It actually does actually read text as to whether the patient may have FH, and it looks at several domains. And this was published in Heart recently. Again, I now work with primary care physicians with this rather intelligent Vietnamese software programmer developed this tool called TARBX, and basically, look, this is what it does. It looks at pathology reports, current medication and past medication, the clinical history and the family history, interrogates the GP databases, generates the Dutch lipid network score, and then on the basis of that integrates the number of cases that the GP should assess. And just to take you, and it generates, as it were, the risk of the patient having FH. It's incredibly fast. In this particular simulation, real patient, 3,708 cases were reviewed, 360 were generated by Dutch Lipid Clinic Network, and of those 32, those were further assessed and 10 were generated. And in terms of generating the 32 patients, that only takes about 10 minutes, really. So you can actually go to a GP surgery, interrogate the medical records using TARBX, and tell them, look, you've got 32 patients that you need to assess further or refer to the specialist clinic. So in 10 minutes, you can generate 32 cases that the GP can either refer or evaluate themselves. So I'll come back to this later. I think this tool is quite important. A note about cascade screening that Borg referred to earlier, and in relation to the case that was discussed, I mean, the point about it is that the index cases generally start with parents and then work with children, although reverse cascade screening is an approach that has been promulgated but yet not adequately tested. It really has to have consent of the index case in a civilized society like Britain and Australia and Greece. Apparently, in the Netherlands, you don't need consent to the index case. You just get on with it, really. They knock on your door at 3 o'clock in the morning and want a DNA sample. It's a completely different story, actually. So you have to follow the legislation on confidentiality. In the Netherlands, if you actually don't screen for FH, you're breaking the law, actually, apparently. So, I think they've got different legislation. It depends on countries. I think there has to be counselling of family prior to testing, and that's important to the question that lady asked there. And at present, that screening should be coordinated centrally. Otherwise, it's very difficult, in primary care to do it. Although we are looking at ways where it could be coordinated in primary care. The other thing to say is that cascade screening based on genetic testing is cost effective. And the cost effective for adults here, it was about 3,565 Australian dollars quality adjusted life year gains, which is highly cost effective. So hence, genetic testing and statin treatment is cost-effective in preventing CHD in families at risk of CHD, and that information has to be used when you're lobbying for government support. It's important when you're dealing with FH to find out what your patients feel, and this is something that interested me because we usually live in our ivory towers in clinics, and we talk about DNA testing, and we talk about drugs and all this kind of business. So we started a program of finding out what's inside the head of people with FH. And I'm very honoured to have my colleague Martin Hager, who's Professor of Psychology, previously in Cambridge and now at Curtin University in Perth. So this initial sweep of the problem is that patients were actually interviewed not in the clinic but outside, in a different environment where the doctors and nurses weren't there, and the responses were very interesting. They agreed with cascade screening, but they wanted assistance in contacting relatives. They recognized that drugs were important, but they were very fearful of the side effects. And they tended to feel that with this condition, lifestyle measures like diet weren't particularly useful, which is actually quite surprising. And they were most interested in knowing about whether they had atherosclerosis, and less interested in knowing whether they had a mutation or not, really. So, in other words, they wanted to know that the drugs were safe and whether they had the disease or not. And I think someone asked earlier here about what other tests could you use for risk stratification. And to see what matters to patients is, can you tell me, doctor, whether I do have atherosclerosis or not? So when dealing with adults, and this is from the various consensuses, phenotypic or genetic testing increase accuracy, look at other cardiovascular risk factors, but what people wanted to know is whether they had atherosclerosis, and imaging may be useful. So this is coronary artery calcium score in a patient with FH, age 42. It could have been Borg's patient. Calcification left anterior and left circumflex and in aorta. So that's a very useful tool for motivating patients and for managing patients. These sort of patients, we do this routinely in our clinic now, would then progress onto a functional test, and some have been found to have myocardial ischemia and have proceeded to bypass surgery. Calcium score is can be misleading, and these are two CT coronary angiograms, which we also do as part of clinical service in patients with coronary artery calcium score of 0. But you can see here in the LAD, this patient does have quite an obvious soft plaque at the origin of the LAD, and this one doesn't. So the presence of a soft plaque, and particularly if the stenosis is quite marked and above 70%, is quite important. So imaging is an important approach to risk stratifying patients. I'm often told, but show me the evidence. Where is the clinical trial evidence? And my response is, well, we're dealing with individual patients. This patient, may well have a heart attack because that's an unstable plaque. I'm not going to do a clinical trial on this at all, actually. And then moving on to management now, Borg gave you this marvelous exposition on LDL cholesterol burden and life trajectories, and we're trying to convert homozygotes into heterozygotes and heterozygotes into the background population. And that risk varies according to a number of factors, including Lp(a), diabetes, hypertension. Diabetes, hypertension, actually quite common amongst patients with FH and the older ones. CKD and hypertension, major driver of the risk of CHD and a recurrent event. So I think when you're managing these patients, it's not just about cholesterol, it's about managing weight, anti-smoking advice, grappling with Lp(a), and managing diabetes and also hypertension. It's quite important that those other risk factors are not missed out, and maybe managing postprandial hypertriglyceridemia. So the treatment options, a diet, established drugs that you all know about. I'll say a little bit about Probucol because there's an interesting story about Probucol later. The newer agents, monoclonal antibodies against PCSK9, antisense about ApoB, MTP inhibitors, and more radical therapies like lipoprotein apheresis and liver transplantation. A heart-healthy diet is important, and together with drug therapy, 50% reduction in LDL cholesterol, and the targets that Borg referred to earlier, less than 2.5 or less than 1.8, according to background risk. Certain combinations may be used, bile acid sequestrants, niacin. I think there's probably still a role for niacin in severe FH. The clinical trials didn't include patients with FH. Niacin actually does drop your LDL and your Lp(a), so I certainly wouldn't exclude it. Very difficult to get people on niacin now that there's been bad press out there about what it does in clinical trials, and the likes of Jane Armitage and Rory Collins saying it actually kills people. They're analysing data most of the time. It doesn't kill people, actually. It kills people if you put inappropriate people into clinical trials who haven't got hypercholesterolemia, actually, But you get these sort of, marketing exercises out of the Oxford stables, a load of nonsense, really. You can use niacin in people with high Lp(a) and high LDL cholesterol. They weren't in those trials. Probucol, that's another load of nonsense, a drug that's been cast aside because it lowers HDL. I think there is a case for Probucol in severe FH, and there is good evidence from Japan. Fibrates, if there is hypertriglyceridemia, and clearly with all these drugs, it's important to monitor side effects, and the one to watch out here is glucose in case of emergent diabetes and renal function. Now, concerning children, again, consider statins in heterozygotes by the age of 8 to 10, ideally certainly before 18. And the targets here are less than 4 with low-dose monotherapy, less than 3.5 with the addition of ezetimibe if required. I point down here that boys and girls should be treated at similar ages, because girls can miss out because you're not going to have them on LDL cholesterol lowering therapy, statins, etc., during pregnancy, and lactation because of potential risks. And again, that's an interesting consultation about what to do about pregnancy, lactation, how long should a woman be off statin therapy. But it's to be on the safe side, best to start them both at the same time so that women have time to catch up. In children, you should really use the statin that is licensed in your country for children, because if something goes wrong, really, you could be had. Higher doses of potent statins if the child has homozygous FH. You've got to monitor development and biochemistry. And of course, you have the issue of adolescent girls, pre-pregnancy counselling, and contraception use before a statin. I think it's important here again to take a history, particularly with contraceptions. Some of the hereditary thrombophilias are perhaps more common than you think. Antithrombin 3 deficiency, homozygosity for factor V Leiden, particularly with elevated Lp(a). I've had a number of women who come in who've developed deep venous thrombosis and pulmonary emboli, elevated Lp(a) above 1 with factor V Leiden mutation who've gone on the pill. Bang, gone, So it's important when you're dealing with contraception, when you're dealing with women, when you're dealing with the issues of elevated Lp(a), that you are well aware what the family history is. So this is where cholesterol and thrombosis meet. Achieving targets in people with high LDL is problematic. As you've heard, a small proportion of people get down to these very low targets that Borg referred to, 2.5 and 1.8. Very difficult to get people down to there on average. There are some people who've got FH who teeter actually around the target levels, but they are the minority. So the approaches to lowering LDL in that down to those very low ranges, particularly in high-risk individuals, include the antibodies against the PCSK9 cell surface regulator, ApoB antisense, MTP inhibitor, CETP, and ApoA antisense. I'll say a bit more about this tomorrow, so I won't talk a lot about that. So PCSK9 inhibitors, alirocumab and evolocumab, certainly lower LDL in a dose-dependent manner. Lower LDL cholesterol in a time frequency dependent manner, with additional to statins and additional to ezetimibe. But in fact, although they have been registered in certain countries, the reimbursement rates for heterozygous FH have not been met, at least in Europe. And certainly in Australia, there's no reimbursement for heterozygous FH, but there is for homozygous FH. Going on a PCSK9 mAb, as you can see, whether you've got severe or less severe FH, a greater proportion of individuals attain those targets, as you might anticipate. And the other returns are a reduction in ApoB, as you would anticipate, and there's 25 to 30% reduction in Lp(a). Since Borg showed that the LDL receptor is not involved in elevating Lp(a) by proxy, it would appear that this mechanism is LDL receptor independent and probably due to an increased secretion or assembly of the Lp(a) particle in the plasma. So it could work in a sense, although not exactly the same as ApoA antisense, but that is still being debated. If you're homozygous FH, it works well if you've got a defective allele, 2 defective alleles, 31% reduction. If you've got 1 defective but one null allele with a PCSK9 mAb, 21% reduction. If you've got 2 null alleles, it doesn't work. I've got a true homozygous FH with 2 null alleles, and the poor girl just doesn't respond to PCSK9 mAb. CETP inhibitors, this was going to showed quite a bit of promise. This is the REALIZE study out of the Netherlands. CETP, as you know, prevents the heteroexchange of neutral lipids between ApoB containing lipoproteins and HDL, and additional to background therapy, a 35% reduction in LDL cholesterol and a monumental increase in HDL cholesterol to 90%. The clinical trials, as we know, we'll talk about that again tomorrow, have not proved positive. So the implications of these changes for FH is still debatable. I think if the clinical outcome trials prove uninformative, then I don't think that CETP inhibitors are going to be employed in the space of FH. There are other issues with anacetrapib, which is the early one that's still alive, that will prevent its use, and that is to say it's high lipid solubility. So at this point in time, I want to introduce Probucol again, because Probucol, by contrast to CETP inhibitors, actually increases CETP. And I mean, Yugi Matsusawa, who's the president of the IAS, tells a very interesting story that he was taken to New York to where he sat in a room at Pfizer, with the greats of HDL. And he was the only one out of 10 people that said that he didn't think CETP inhibitors would work. But what you needed to do to regress atherosclerosis is to increase CETP as Probucol did. And everyone shouted him down. Well, that's exactly what Probucol does, actually. So this is data, I think it was from Mabuchi, but showing evidence that, Probucol actually does drop HDL and drops LDL. And it drops HDL because it's a CETP agonist. It actually stimulates the process, almost stimulates reverse cholesterol transport via the other route. It has a strong antioxidant effect, and it regresses tendinxanthomas. And here is showing a correlation between the reduction in HDL cholesterol and the regression of tendinxanthomas. So almost as if the reduction in HDL correlated with the regression of disease, but it's been totally and utterly forgotten, and it's been slammed and put to bed with the statins. I think there is a case for Probucol in severe FH, in homozygous FH, and I think we should not ignore it. The other new therapies are mipirmersin, lamiptide, and the monoclonal antibodies that I referred to should be considered in people with homozygous FH, and certainly in Australia, if you've got homozygous FH, you get reimbursement. Experience with these agents in those on apheresis is limited, and experience in the use of PCSK9 inhibitors in children with homozygous FH is limited. But there is some experience with mipirmersin and lamiptide. Very briefly, mipirmersin is antisense oligonucleotide against ApoB. It decreases the hepatic secretion of ApoB and the transport of ApoB down the cascade, including Lp(a). I mean, it's a marvelous drug in principle. It's drug specific. Unfortunately, no one can take the flaming drug. And I have to tell you, despite all the marvelous papers that have come out of South Africa, I can tell you not a single patient on those trials will ever take this drug again. I mean, it's an awful drug. I don't know what experience you've had, actually, but I could not get anyone to take it, and I certainly don't want it anywhere near my clinic. Having said that, in homozygous FH, marvelous papers in the Lancet, except people can't take the drug, that there is a 24% reduction in LDL cholesterol, and again, a synthesis of the data with mipirmersin. Patients with homozygous severe hypercholesterolemia, heterozygous FH with CAD and HC at high risk of CHD, very high baseline levels of LDL cholesterol against background therapy, significant reductions in LDL ApoB and Lp(a). So, in principle, it's a good drug. Its pharmacology makes sense, and it simply just switches the tap off out of the liver. So it's not the end of history. I mean, its present form, I don't think this drug, in my view, will ever get anywhere. But I understand that ISIS have changed the, they have a ligand conjugated form of the gapmer, which is highly tolerable. So I think if they can change the tolerability, mainly in severe injection site reactions, I think we may well be home and hosed. MTP inhibitors are as expensive, in fact more expensive than mipomycin, and of course the lamipipime is the drug in question. It also reduces the hepatic output of B100 by inhibiting MTP within the liver. It causes fatty liver too, and again decreases the transport of ApoB down the VLDL-IDL cascade. It acts not only in the liver but also in the intestine. So as a consequence, steatosis is an issue, and hepatic steatosis can be a problem. So these are results from Marina Kukel, published in The Lancet a few years ago. You see here a average 40% reduction in LDL cholesterol in homozygous FHs. There is a reciprocal increase in liver enzymes related to liver fat, an increase in hepatic fat by MR spectroscopy, but long-term studies suggest that this is not damaging, does not cause cirrhosis. A number of centers that use apheresis testified to the value of lamipipime. I've had one patient that Agerian was interested that I should prescribe at a cost of about almost $750,000 a year. I said, well, we can't, certainly my government, my CEO laughed at that. And really, the cost of these drugs are absolute nonsense. The young lady in question developed severe elevation in liver enzymes and marked intolerance to lamipipime. So again, I'm highly suspicious about whether these agents will fulfill a major role, particularly with the advent of PCSK9 monoclonal antibodies. Now, it's not everyone's experienced that. I know Claudia Stefanuti in Rome testifies to the value of lamipipime in a variety of children, so children with severe FH on apheresis. Apheresis should certainly be offered to all homozygous patients and heterozygous FHs with coronary heart disease who are refractory to drug therapy. In children with severe homozygous FH by the age of 5, and Claudia's done probably the youngest apheresis. She's done it in a child of 2.5. Should not delay longer than 8 years. Again, because as Borg said earlier, that despite moderate control or good control of LDL hypercholesterolemia, because background disease, atherosclerosis can progress, particularly in the aortic valve, echocardiography of the aortic valve, stress echocardiography, carotid ultrasonography, and a stress test is recommended. I won't go into the various forms of apheresis at this stage in the interest of time. To summarize here what is achievable in homozygous FHs, starting with diet, starting an LDL of 13 with a statin, ezetimibe, PCSK9, mipomycin, lamipipime, and all lipoprotein apheresis can get their LDL cholesterol down to about 2 to 3 millimoles per litre, which is a major advance. This is a patient of mine who's in the Midwest of Western Australia, who lives on a farm, and Mandy's 38. She's compound heterozygous FH. Someone got the diagnosis wrong at the age of 12 when she couldn't wear her shoes properly and chopped out, both her Achilles tendons. Then the diagnosis was made. She went on Questran, which she hated, went onto a statin, and then came down to my clinic, and we put her at about at the age of 38 years ago on apheresis, and this is the swinging pattern of lipoprotein apheresis using cascade filtration every 2 weeks. So she flies down about 2.5 hours from the country to have apheresis, and she's also got aortic valve disease and hypertension. So here we are, 420 milligrams of evolocumab monoclonal antibody we decreased the frequency of apheresis, and she's now off apheresis and working happily in the farm. So I mean, this is a great success for her. I mean, it's absolutely transformed her life. She hasn't got to fly down every 2 weeks. The government doesn't need to pay for her. So there's a remarkable cost savings, and that's why the government in Australia will invest in someone like that, because they're saving on apheresis and improving quality of life. So Mandy is very happy at the moment, and her 2 daughters have heterozygous FH and are very responsive to low-dose rosuvastatin 10 milligrams and well at target. Liver transplantation should be considered for younger patients with homozygous FH who cannot tolerate lipoprotein apheresis and drug treatment, and we have experience of 12 liver transplants in Australia. How we found out about them is an interesting story that I won't delay the presentation, but I mean, there were people having liver transplantations who weren't going through the normal channels of seeing lipidologists, and mainly in the state of Victoria, when I mean, Victoria is one of the most populous states in Australia, and we consider, well, why haven't they got enough? You know, we've got more homozygous FHs down there. And I had a research fellow doing an attachment to one of the hospitals, and he got talking to one of the liver transplant registrars. He said, "Oh, hang on a minute, we've done a few of those." Referred directly by the paediatrician. So when we looked at the liver registry, they'd done about 12 in the last 10 years. So, you know, it is happening with satisfactory results. And that summarizes what Borg indicated earlier, the plan for the management of homozygous FH from this consensus paper, which Marina Kukel is the first author. I won't take you through it, but really just to say that one outcome of failed apheresis is liver transplantation, that there is approval by the FDA and the EMA for lamiptide. Mipomersin is not approved in Europe, and quite rightly so. Future therapies, PCSK9 inhibitors, yes. CETP inhibitors, I doubt it. Gene therapy, there is a trial at the moment going out of Penn that involves Dan-radar. So let's get now to more fundamental things about the models of care. We were talking about the models of care earlier. And, you know, a model of care is really a system for attempting to incorporate the best available evidence to improve the health outcome of your patients. And these are models of care that have to be designed in a local context. So your model of care in Australia is not the same as the model of care in Copenhagen or in Boston. It's the model of care that operates in Greece, and you've got to design it to the local context. The care of FH is, because it's a chronic disorder, involves multidisciplinary services that have to be integrated with primary care. You know, it's a myth that all FHs have got to be in centres of excellence. I mean, you know, 70% of it, as you'll see, can be out with the GP, and that's what you need to identify. Clearly, you know, cardiology, pediatrics, genetics, imaging, transfusion medicine for apheresis, nursing, dietetic psychology, pharmacy, pathology are all involved in the model of care. Now, this is a model of care that has been published in principle, and it's a model of care that GPs designed. So I went out there and said, look, I don't want to tell you what to do. This is the evidence, right? How do you think, knowing what the services are like in this town, this state of Western Australia, how do you think it should happen, right? It may not apply to your context, but this is what they came out with. They divided the integration of care into primary and tertiary. They suggested that they should be focusing, Borg quite appropriately, on LDL cholesterol greater than 5. A Dutch score greater than 5 should then suggest FH, and this could come either from the laboratory alerting them that there was a cholesterol greater than 5, or from screening their electronic medical records. Well, there were two things. Now, a decision could be taken, and that was the preferred one, to assess the complexity of the patient in association with the specialist centre. I mean, not all patients need to be referred. The low complexity patients, like one of Mendy's daughters, age 16, with an LDL cholesterol of 4.9, who responded very well to a statin. I don't need to see her. She can stay in primary care. A high complexity patient with, I saw one about 3 months ago, a Filipino woman who just married a Western Australian man, and she had homozygous FH with quintuple bypass. She requires apheresis and a PCSK, and that person needs to come here. And in the intermediate complexity, patients can be, as it were, shared. But it's quite clear that the vast majority of FHs in the community, this high prevalence of 1 in 200 or so, can be managed in primary care. You know, certainly you can put them into a registry, but you don't need to keep them. And you need to keep, you know, your centres, Genevieve centres, we need to be dealing with the most complex patients. In terms of cascade screening, their advice was that, yeah, for the moment, keep it centrally, particularly if you can fund it, but explore ways where the GP can be involved in cascade screening, and that's such a study that we're proposing at the moment. So the organisation of care, so that's one point I want to make about this, that in order to make this work, you need to make champions of GPs. It's not what you say. Give them the data, be nice to them, be humble, say, look, I don't know, I'm not an expert here, you know, what do you think, you know, and then let them run with it, and then become champions, and they're it. I mean, the chaps that I've been working now, you know, writing papers, they're writing grants, you know, they've got opinions, you know, I ask them questions. So partnerships are important between academic and professional organisations. A registry of patients and families is fundamental locally, and we can talk about that very briefly. And it's very important to have a support group of patients and families. Absolute requirement. I don't think you can run a service unless you've got a registry and a support group. If you haven't got that, you need one. So registries, we articulated this in a paper, I think with Josh Knowles was it before he actually built his own registry. But you know, international registries, you know, have a major role. And I mean, I was interested in developing one, and you know, we have made some progress with registries. I think, you know, there's sort of clinic databases, and then there are registries that are well designed. And by that I mean, you know, web-based registries, that platforms that can talk to each other. I think once you get into that, it's a real game changer. There's a lot of people got registries around here. You know, everyone's got a registry. I mean, there was a recent review in Current Opinion Lipidology on registries, and when they did the review, there were just clinic databases. Clinic databases that, when you look at them, are just, you know, high-risk patients that don't tell us much about FH other than what we know. It's like the data out of that we quote in the BMJ Borg about the effects of statins on outcomes. I mean, that's from a high-risk clinic. You know, what about the rest of FH? And I think, you know, we need to create these mobile platforms that allow GPs to put patients in. We need to, you know, all be part of a good web design platform where data can be pulled together. This is the design of a web-based registry that we're operating out of Western Australia and can integrate all the states, including New Zealand, and at the moment, proof of principle, can integrate, you know, 6 centres in Asia Pacific. It's there's the public internet, that's the remote user, there's a firewall, 2 firewalls, that's the registry, patients and data elements. The modules are clinical, a genetics one, cascade screening, cardiac imaging, and apheresis. You just use you don't need to populate all the modules. If you haven't got enough data, you just populate what you have. But there is a basic set of data elements, similar to the data elements that were published in the FH Foundation paper recently communicating in Circulation Genetics. So these summaries, a summary on the models of care, that they have to be designed according to the local context. It's absolutely vital to develop research and audits to close the evidence gaps. And the partnerships have to be established with diverse stakeholders that I've referred to earlier: support groups, foundations, government organisations, health economists, policy makers. So what facilitates better care of FH? Well, a number of things need to be taken into mind. Is to be absolutely focused and dedicated, to collaborate with others, share information, empower colleagues, empower patients, to market the exercise, education, publication, sort of things that are going on here, advocacy, enablers, influencers, creating champions, getting international support, working with industry, persisting, and taking courage, because, I mean, you know, sometimes you're taking things on that are a bit out of your depth. You don't know how things are going to go. But look, everything will be all right on the day. So what about patient support groups? Very briefly here. Patient support groups, advocacy. Do you do much advocacy in Greece about FH? Well, if you don't, you probably should, actually. You know, everyone should advocate. Advocate is purely the process as to, you know, the what is now to what it should be, and it's a process of trying to influence change. The most important people group to advocate for FH are the people who actually have FH. I can tell you lots of stories where I've expended a lot of energy in trying to advocate for FH with government departments, with the heart foundations, taking the great luminaries in the world in FH that used to visit me in Perth, and really we never got a lot out of it. They were interested in what this professor from Oxford, you know, was saying about this, that, and the other, you know. But as soon as I started taking, someone tapped me on the shoulder, and I think it was probably Michael Livingston from when he was, he said, look, the patient support group to do that for you. Now, as soon as I started taking patients to visit health ministers, started patients to visit, you know, and everything started to happen. They listened to patients. They're very suspicious of professors, actually. Fair enough, exactly. That's what I thought. Yeah, my lips are sealed when I go in there. So what can patients do? Well, they can advocate for a cure. They can drive research, awareness, and funding. I mean, you know, particularly active individuals can. We have the chair of our family support group is actually driving, you know, research into web design at the moment, which is exactly what we want. They can be involved in longitudinal research. They can advocate for faster approval of drugs. They can do many things. You know, they can advocate for healthcare system improvements. They can improve patient-provider communications and improve the integration of care. So I think, you know, I'd strongly recommend that if you haven't got a patient support group, you get one and you focus on advocacy. The last thing I want to, because it's getting late, Dimitri, Genevieve, need to touch on are what the research needs in FH are. Now, this is something that involved a group. This was the research agenda, the American Heart Association scientific statement published in circulation, where a number of items were identified. First on the list was the development of new models of care. And the Americans have a way of putting things. Population science, which is nothing more than what you're doing, actually, is epidemiology, but they call it population science, you know. And what the devil's population science, actually? But anyway, they want more epidemiology on FH, the sort of thing that you're doing. Basic science, you know, cell work, mechanism of action, why does Lp(a) do that? New mutations, genetic testing, life course, particularly starting in youth. Clinical research, you know, clinical trials, mechanism of action of drugs, safety, and patient-centric research, you know, involving the patient in research, in not only, you know, by that I mean patient-centric research, doing research that patients actually want and can have input to. I have to say, in Australia we have a system called the NHMRC Centres of Clinical Excellence, And unless you have a patient input into the research, you just won't get shortlisted. You won't even get interviewed, actually. So patient involvement in research is important. I think I probably want to stop there, actually. Other things that we're doing in Australia, this is an IES-funded project looking at FH in 10 countries in the region. And there is a link with the EAS Studies collaboration that's headed up by Kozik Ray. And that's all I want to say. Thanks very much indeed.